This video will discuss function and etiology. In previous videos, the plantar fascia was described as a fibrous sheath on the sole of the foot. The main functions of the plantar fascia include supporting the medial longitudinal arch as well as acting as a shock absorber as the foot bears weight during walking and running. The three main arches of the foot include the transverse, medial longitudinal, and lateral longitudinal arches. The plantar fascia mainly supports the medial longitudinal arch, which is then supported by the calcaneus, talus, navicular, cuneiforms, and the first, second, and third metatarsals. As I previously mentioned, the plantar fascia acts as a shock absorber during the weight-bearing phase of the gait cycle. During contact, the heel strikes the ground and the tibia turns inward as the foot begins to pronate. Pronation consists of the movements dorsiflexion, eversion, and abduction. As the foot pronates and continues into the rest of the stance phase, the arch begins to drop and stretches the plantar fascia. Normally, our feet accommodate and absorb the shock from our body weight and any additional pressure, but if the pressure exceeds normal, then damage to the plantar fascia can occur, resulting in irritation, inflammation, that leads to the condition of plantar fasciitis. The etiology of plantar fasciitis is multifactorial, including intrinsic and extrinsic factors. The intrinsic factors include biomechanical issues, obesity, and aging. The extrinsic factors include increased activity levels, repeated trauma. Some of the biomechanical issues first include foot deformities, like pes cavus and pes planus. Both of these deformities are predisposing to plantar fasciitis. Pes cavus can also be distinguished as having a high arch. This foot deformity decreases subtalar joint pronation. Therefore, as you step, it is not a fluid motion, but more of a shearing force on the fascia. Pes planus can be clinically seen as a flat foot. This deformity leads to the overstretching of the fascia, causing irritation. Another biomechanical issue is limited dorsiflexion, which can arise from any of the foot deformities mentioned earlier. Dorsiflexion is the upward movement of the foot at the ankle joint. Normal dorsiflexion range of motion is 20 degrees. If the range of motion is less than normal, this can be a factor in plantar fasciitis by creating pronatory compensation, thus causing higher loading forces on the plantar fascia. Obesity is another etiology of plantar fasciitis, from the increased weight applying pressure to the sole of the foot. A BMI of more than 30 kilograms per meter squared is indicative of causing issues to the plantar fascia. Aging is the third intrinsic factor of plantar fasciitis. This is due to poor muscle strength such as tight calf muscles, decreased healing capacity, as well as protraction during periods of rest or if bedridden. Increased activity levels is an extrinsic factor in the etiology of plantar fasciitis. This is seen in athletes and weekend warriors due to overuse, training errors, running on firm surfaces, and improper footwear. Repetitive pressure, such as prolonged standing on firm surfaces, is a relative risk factor and is found in higher frequency in those with occupations like nurses, doctors, and the military. All these factors, including extrinsic and intrinsic factors, can lead to the irritation and inflammation of the plantar fascia.